My topic is post-traumatic exophthalmos caused by a carotid cavernous fistula, a case report. I have no financial interest to declare. So basically, carotid cavernous fistula, they are abnormal communications between the carotid artery and the cavernous sinus which provoke a pathological arteriovenous shunt. They are rare but a lethal complication after trauma. According to Barrow's classification, they can be type A, which are direct connection between the IC and the cavernous sinus, and they are usually high flow and seen after a severe head injury or rupture of any cavernous aneurysm. They are mainly treated by endovascular approach. Type B, C, and D, they are indirect and usually low flow. They are mostly idiopathic and resolve spontaneously. My case was a 55-year-old male resident of UP, a mechanic by profession, who presented with the chief complaint of outward protrusion of right eye, limitation of eye movements, and diminution of vision since the last 14 days. He was apparently well 20 days back when he suffered a motorbike accident, which was followed by swelling and redness of the right eye. There was history of loss of consciousness after trauma, as stated by his attendant. There was no history of any ENT bleed, seizure, or vomiting. He noticed gradually progressive protrusion of the right eye 6 days after trauma, which was associated with limitation of eye movements and gradually progressive diminution of vision. There was a history of increase in protrusion of eyeball on bending forward or after cuffing. No history of any tremor, weight loss, sweating, or palpitation. No history of waxing and waning course. No nasal bleed. No history of swelling in any other part of the body. No history of recent URTI or any known comorbidities. No history of any prior surgery or any addictions. General physical examination was performed, which was within normal limits. Then on ocular examination, the patient denied perception of light in the right eye, whereas in the left eye it was 6/6, and there was no acceptance in the right eye. Then in the left eye, color vision by Sciarra chart was within normal limits. Contrast sensitivity was also within normal limits. Facial asymmetry was present. The extraocular movements in the right eye were limited to -4 in all the directions of gaze, whereas they were full and free in the left eye. IOP measurement could not be done in the right eye due to a tense lid edema. In the left eye, it was taken by GAT. It was 12.2 millimeter of mercury. On examination of the left eye, the lid's conjunctiva were within normal limit. There was a clear cornea, anterior chamber depth was normal, pupil had normal sensation and normal reaction, lens was clear, and fundus examination was also within normal limits. In the right eye, on inspection, Nafziger sign was positive. There was outward protrusion of the right eye. Fullness was seen at the superior and inferior aspect of the orbit. There was a hemorrhagic chemosis, which was evident after lifting the upper lid. A tense lid edema was there. There is bluish blackish discoloration of the skin over the eyelids. Dilated vessels were present on the overlying skin, and increase in proptosis on bending forwards. On palpation on the right eye, there was local rise of temperature over the eyelids. Tenderness was present. Fingers could not be insinuated in the supraorbital and the infraorbital space. Examination by Hertels revealed a 6 mm proptosis of the right eye. Pulsations were felt over the lids, which were synchronous with the heartbeat. There were no palpable lymph nodes, and on auscultation, bruit was heard. Then the investigations, the blood investigations revealed no abnormality. Chest X-ray was also normal. NCCT head was done as a part of trauma procedure. There was an extradural hemorrhage along the right parietal lobe. The right parietal bone, lateral wall of right orbit, and anterior wall of right maxillary sinus fracture was seen. There were bulky extraocular muscles on the right side, along with fat stranding in the extra and intracoronal fat space. A DSA was done, which revealed a direct CCF from the internal carotid artery draining into the superior ophthalmic vein. These are the images. First one shows an MRI revealing the carotid cavernous fistula. Next image, it depicts the contrast CT, which was done, which revealed a dilated superior ophthalmic vein. And the third is the CT angiography scan, which shows the carotid cavernous fistula. Then this is the pre-op photograph of the patient, and on the left-hand side, we can see the post-op photograph of the patient, which shows a decrease in the edema after the post-embolization was done. So this case was decided to be treated by endovascular approach, and after coiling, complete obliteration of the carotid cavernous fistula was achieved. This coiling was done by the neurosurgery department. 55-year-old male presented with chief complaints of outward protrusion of right eye with limitation of extraocular movements to -4 and gradually progressive diminution of vision since 14 days. Examination revealed a tender lid edema with dilated tortuous vessels, hemorrhagic chemosis, and pulsating exophthalmos right eye, synchronous with the heartbeat, 6 proptosis, increase in swelling on bending down, and Bruy heard on auscultation. So cerebral angiography is the gold standard for diagnosing this. And the goal of endovascular embolization was basically achieving thrombosis of the fistula while preserving the patency of the ICA. And diagnosis and management, it is not a simple process as it requires concerted efforts by the neuroradiology, maxillofacial department, as well as an ophthalmologist. And so this requires a high index of suspicion to establish diagnosis and prevent serious consequences to improve the prognosis of the patient. These are the references. Thank you.
You could not take IOP in this case, but did you feel it digitally?
Digitally it seemed high, ma'am, but exact measurement could not be done.
So what is the cause of raised IOP in such cases?
Raised IOP could be due to increase in the episcleral venous pressure, which is basically because there is shunting from arterial to the venous circulation, which causes increase in the back pressure. So the episcleral venous pressure increases.
Thank you. Yeah.
Thank you, ma'am.
Okay, one more question. What is your role in this?
So, ma'am, basically,
the procedure is done by interventional radiologist,
yes,
neurointerventional radiologist.
So the patient first presented to an ophthalmologist with the proptosis of the eye. So it could have, it may have not been diagnosed at the right time. There could be a delay in doing.
Correct. Plus, if you have to intervene, what are the ways that you can intervene in some cases?
Ma'am, like in early cases, we can give a pressure lowering.
First thing, as ma'am said, you have to measure the IOP and
pressure lowering agents have to give in the early period.
Is there any role of conservative management in one of the Barrow's grades? Which grade?
Ma'am, the indirect ones.
So what can you do? Sometimes it works.
So in those cases, the IOP measurement has to be done.
No, have you heard of carotid compression?
Carotid?
Compression.
Yes. Like
will it help?
In this case, it will not help because it is a high flow fistula. In the indirect ones where there is low flow, it can help.
You know how does it act? How it acts, carotid compression.